Okay, hi everyone. We'll go ahead and get started. My name's Mary McLean, and on the call also is William Dixon. We're your co-leads for the Cord Connects educational series, and I have the privilege today of introducing you to Dr. Jessica Bod. Jessica grew up in a family of teachers. Her grandfather taught chemistry, her mother taught biology, and her sister teaches second grade. So during her medical training, she naturally gravitated towards a career in medical education. She is currently the medical student clerkship director and sub-internship director at Yale. Her interests include the creation of programs promoting residents as leaders in medical education. Currently, Jessica is focusing on diversity, equity, and inclusion content in EM curricula, and she has spoken about her curricular innovations locally at Medical Education Day and on the national level at CORD and SAEM. And today she's speaking for us at Cord Connects on bystander interventions for mistreatment in the learning environment. Welcome, Jess.
Thanks so much. Thanks for that introduction. It's such a pleasure to be here talking about something that I'm really passionate about. So this is bystander interventions for mistreatment in the learning environment, and I have nothing to disclose. So we'll start with some objectives. What I'd like for you to take away from this talk is the ability to discuss the prevalence and impact of mistreatment on trainees and the learning environment, to describe the role of supervisors and the institution in monitoring and responding to mistreatment and identify potential barriers to that process, to recognize various forms of mistreatment, and then to apply at least 3 practical strategies for responding to mistreatment of trainees. Some of the deliverables, what I hope you'll be able to take back after this and to bring to your home institutions, is to apply the ERACE framework to the clinical learning environments. We'll talk about what that means. To practice specific bystander interventions to support learners who experience mistreatment in the learning environment. And then to be able to think of yourselves as people who support a positive learning environment in your home institutions, and to think really about how you're going to do that and how you're going to bring that with your own flavor, with your own intentionality to your clinical learning environment. So we'll start a little bit about me. I am the clerkship director at Yale. I'm the sub-internship director. I work with students a lot. And as clerkship director, I'm responsible for the learning environment of students. And that's a scary thing when it's the emergency department. And so sometimes when students experience mistreatment in the emergency department, they report it out, and we have various mechanisms for anonymous reporting or reporting in real time. And I get the amalgamated reports of every bad thing that anyone ever did in the emergency department to a student. And fortunately, these reports tend not to include the egregious activities of supervisors in days of yore. I do not get a lot of mistreatment from attendings, from residents, from supervisors. But what I read about more and what seems to be more pervasive in the learning environment at this time is mistreatment from patients or staff. And you might say, well, what are you going to do about that? The patient encounter was 6 months ago. It's an anonymous report. Certainly, I can't go find the patient and educate them about how not to mistreat medical students. But what the students are looking for is not that. What they're looking for really is for me to create a culture where they get support from faculty and residents when this happens, even if the faculty and the residents are not the perpetrators of mistreatment. And that's where this came about. That's when I started thinking about bystander interventions and how to teach it to supervisors. And in doing so, I hope to kind of instill in all of the supervisors and the teachers in the learning environment a recognition of their leadership role, even when they're not perpetrators. And so to have this sense of, well, it wasn't me, I didn't say that, I would never say that, and to kind of evolve more toward, I care about what's going on around me. I care about what's happening to my learners and what they experience when I'm in charge of their education in the emergency department, and I can do something about it even if I'm not the perpetrator. And so we'll start with the question, what is mistreatment? What am I talking about? What does it mean to experience mistreatment in the learning environment? The medical school GQ graduation questionnaire defines mistreatment as any behavior, intentional or unintentional, that shows disrespect for the dignity of others and unreasonably interferes with the learning process. It's like a lot of behaviors. And so we'll talk about some of them. So breaking it down, what kinds of mistreatment have I read about in my reports? Do I think about? Do I worry about? Certainly, the more egregious forms are easier to spot. So sexual harassment and impropriety, discrimination based on race, religion, ethnicity, gender, or sexual orientation. These are things that are usually a little easier to spot. Some things that might be harder to spot if it's being perpetrated, especially by people higher up in the medical hierarchy, would be psychological punishment. And I remember when I was a medical student on a surgical rotation, I was rotating with another student. We were together, and the other student was perceived of as irritating. And the fellow said, you get a certain number of questions and then you're cut off. And that's like a kind of psychological punishment to make the person worried. Is my question annoying? Am I annoying? Am I horrible? And I'm going to be cut off and then I'm not allowed to speak for the rest of the day. So like things like that, we hope they don't happen. But as recently as when I was a medical student, which I hope is not perceived of as like days of yore, this sort of thing was going on. Physical punishment, the throwing of instruments is what comes to mind. It's certainly things that I have seen as a trainee. I have not had this on a report that came to me as a clerkship director. Humiliation, so this kind of like, even like, how could you not know that in public? A way of shaming someone for what they don't know. Even if you perceive this as a way to teach somebody, aha, you need to go study. But if it's done in a shaming way, if it's done in public, that's humiliation and that's mistreatment. Use of assessment in a punitive manner can be considered mistreatment. If you're going to kind of save up all your ire for your trainee for their dean's letter or something like that. Use of derogatory language, so put downs, mild put downs, or if you have a team where there's even a playful perception of kind of calling somebody slow, calling somebody lazy or sloppy, like this is derogatory language and that's mistreatment. And then kind of overt slurs is definitely mistreatment. On the third line, we have the more difficult to catch stuff. And I want to highlight those things. One is problematic compliments. And I do get those in my reports where folks feel singled out because of a physical or perceived ethnic attribute that they have that is kind of applied widely to a group, and it's verbalized as a compliment, as something positive, and yet it feels not good. And microaggressions. And so we're going to talk about microaggressions, but there are these more insidious ways of singling somebody out that may be very specific to a certain group of people that might be difficult to catch if you're not clued into what these microaggressions imply. So fortunately, I've never had to intervene on physical mistreatment. But what we can conclude about verbal mistreatment is that it is common. It is sometimes insidious. And these are the sort of things that you might not be attuned to if you're not looking for them. And it's kind of unclear how to respond, right? Words, they go out there and then they're gone. And if you wait long enough, you might forget what was said, or you might not even register what was said. And sometimes it's hard to know what to do. Just to emphasize that this is not only a problem of trainees. This was a Medscape survey done of folks who are kind of at the terminus of their training. They're professionals, doctors, nurses, nurse practitioners, and physician assistants. And they report at varying levels offensive remarks made by patients about their age, their gender, ethnicity or national origin, their race, their weight, political views, religion, accent, perhaps a comment about where they've been educated, if outside the US, sexual orientation, and any bias at all is actually quite high, 59% for doctors. But we can see that where the folks who experience verbal prejudice expressed by patients, it's not negligible. It's, by age, gender, ethnicity, and race, it's quite a lot more than we would hope. Similarly, medical trainees, and we're talking about residents and fellows in this particular study, report experiencing some form of mistreatment during training. A majority of them do. The most common is verbal mistreatment, and who the perpetrators are, typically consultants, patients and families, and then their peers, other fellows and residents. Most of the literature on mistreatment of medical students focuses on mistreatment by supervisors. So there's sort of less of this focus on mistreatment by patients, although this is the majority of reports that I receive when it comes from a patient. There is an emerging literature on mistreatment by patients. And it's something that I think about because it's really complicated. It's really hard to know what to do with a patient who's mistreating someone on your team. And when I think about it, I think about what happens. Why do I care? Why is this so important to me? And it's not because necessarily someone is going to take it to heart, right? It's not necessarily because this person's going to be wounded in their soul, although that might occur, and that's horrible if it does. But because it takes my learning environment and it takes a place where I want people to grow and to thrive and to step into themselves as physicians, and it makes it a bad place to be. And what goes through the minds of trainees, and I've had discussions with trainees about this, and I've experienced it myself. What happens when that mistreatment occurs, and what happens when it's directed at you? Well, you can't learn anymore. The learning stops. The mode of going on, absorbing, assimilating, evaluating, thinking, that goes out the window because you are now a target. So the mode of thinking that takes over is a fight or flight kind of response. The adrenaline goes up, the heart rate goes up, there's some, hypervigilance, and that kind of mind that can process, that can take in, that can learn is no longer online. The feeling of isolation when this happens is one of the worst feelings that people report to me. This sense of being othered, being separated, being singled out. And also, if nobody responds around you, you might wonder if you're like a little crazy or like, am I the only one who heard that? Am I the only one who saw that? Am I the only one who's bothered by that? What does that say about me? And so this kind of sense of big threat coming from the outside, I am now outside of my zone of safety because I'm different from everybody else, intensifies that feeling of being targeted. There's a pretty difficult sense of role ambiguity when that happens, right? Because it almost feels like now the perpetrator and the victim are on different sides. And the question of where do I fit in the team becomes one of, am I included? Am I part of this group of people, or am I outside of them? Are they going to have my backs? Do they care about me? And so this sort of construct of a group that we create, of a team, of a bunch of people working together, one person is now unsure if they're really included in that group. And that can be very difficult, and especially if you're trying to step into the role of physician, step into the role of doctor, and you're not solid in that role. That can be very, very difficult because you're kind of not sure who to be in that moment. Am I myself? Am I someone who's been aggressed on? Am I the doctor? Who am I? And finally, the difficulty of struggling with empathy, especially if the perpetrator is a patient, folks get that sense of, I want to be empathetic. I'm the doctor. I'm the medical student. I'm the resident. I'm the person who's taking care of, but I don't feel I can take care of because I feel hurt. I feel uh, threatened. And so the sense of how can I maintain an empathetic stance toward this person who has perpetrated aggression on me is a difficult thing, and one that really needs to be worked through when it happens. So I'm just going to summarize this part of the talk and bring home the main points that I want you to take away. That mistreatment of trainees is common, particularly verbal mistreatment, that it impacts the learning environment and makes learning stop and makes it very difficult for trainees to continue in their role as learners. And trainees report that team leaders don't address incidents of mistreatment, and that's what they want from us. They don't want us to sanitize the learning environment and make it go away, although that would be very nice. What they really want is a leader, someone who is supervising, someone to show, I see you and I care. So the next part of the talk, we're going to talk about how to do that and how to be that person. So barriers to addressing mistreatment, right? There's so many barriers. How in our litany of things that we need to do can we recover from a moment where a trainee feels mistreated? How can we find the time? How can we find the right tone? How can we intervene when we might upset a relationship? It's very difficult. It's very tricky, and that's why we're here today. So some of the major barriers, other than time, because time is, time is a barrier to doing assessments, time is a barrier to so many things in education, but other than time, the major barriers to addressing mistreatment include a faltering of the leader, someone who had an opportunity to do something and didn't take it. Sometimes that's a failure to recognize mistreatment. And I think that is important. We're not doing a talk here today on microaggressions and how to recognize them, but just knowing that there are things outside my experience that are microaggressions, that are problematic, that can make someone else feel small and othered, that I might not even know about, is something that we should each probably think about and think about how to learn more about that. Because if we don't recognize it, we really can't intervene on it. Sometimes people just don't know what to say. They're worried about making it worse. They're worried that if they draw attention to the incident, they're going to make that person feel even more singled out and even more small. And so that feeling of not knowing what to say, it sort of morphs into this idea of, let's just keep going. It's better if I don't say anything at all. Sometimes there's a real concern that you might jeopardize a relationship with the patient, especially if the patient is doing something where, a group of people are kind of given a lot of positive feedback, a lot of, appreciation from the patient, and then another group of people are not given appreciation from the patient. And so there's like a kind of dichotomy that can be set up sometimes, and not wanting to jeopardize that feeling of, well, I can take care of this person. And I have a working relationship with this person, even if my teammate does not. That can become tricky. And then there's the sense of the perpetrator is a colleague, either a peer, another physician, or a member of the staff. Would you put that relationship in jeopardy in the name of supporting a student who's going to rotate off your service in a week and a half? You're going to have to finish a shift with this person. You're going to have to finish 10 years of work with this person. Is it really worth it for you to step in and intervene? So the way that I'm going to advocate for intervening is based on the ERASE framework. There's so many frameworks and ways to conceptualize doing a bystander intervention. And certainly you can go look and see if there's one that works best for you. There's one called OUCH. There's one called the Ds. But this is the one that I like the best, and I'm a little biased because it was developed at Yale and it's the one I learned first. But what I like about it is that it focuses on the learning environment. Some of these other frameworks are developed more kind of for a more normal job, right? Like some kind of corporate situation where there's a specific hierarchy, and it doesn't take into account necessarily this like triangulation that can occur with patients. And the other thing is that it it was originally developed to help attendings support residents. And so it assumes that there's a learner there. It assumes that there's someone who is like profoundly disempowered in that environment, who may be a witness or who may be the victim. But the idea that there's a teaching relationship involved is kind of baked into this framework. That's why I like it. Um, Although originally developed to help attending support residents, I feel it has wide application for senior residents to support juniors, for everyone to support students, for all of us to support each other. And the details of how it was developed can be found on MedEd portal. So we're going to go through the erase framework, the letters, and try to what those are trying to cue you. The first E is to expect that such events will happen and prepare accordingly. The R is to recognize that mistreatment is happening. The A, to address the situation in real time. The S, to support the learner after the event. And the E, to establish or encourage a positive culture. And we'll go through each one. So expect that mistreatment will happen and prepare. Congratulations. Everyone participating in this webinar has checked off the first E. But the idea that anything you do under pressure, whether that's pressure because a patient is crashing or emotional pressure because tensions are running high, is something that you can practice and get better at outside of the area of pressure, that you can then kind of employ those skills that you learn outside when it happens in real life. So participating in workshops like this, practicing, thinking about it, can go a long way to bolstering your confidence to do bystander interventions and to do them well. You can also kind of expect that something might go down under certain conditions. Like if a patient is agitated, if a patient is inclined to lashing out because they are disinhibited in some way, that's maybe when your radar should be up and kind of you're looking at your team. You might be wanting to think about how what's going on around you is affecting your team. And another scenario might be unhappy patients, patients who are waiting a long time, patients who are in pain. They might feel the need to lash out against a system that is treating them not well, and to lash out against someone who is otherwise disempowered for some reason within the hierarchy. So for the R, we need to be able to recognize mistreatment. And I talked about different kinds of mistreatment that occur in the learning environment. But I'd like with the R to kind of bring the idea that recognizing mistreatment doesn't just mean kind of knowing about it, registering it when you see it, learning about the mistreatment of others outside your own experience that you perhaps didn't know was a form of microaggression or a form of mistreatment, but also to consider your own desensitization. Being an emergency physician is a pretty hard job. And if we let every microaggression, if we let every derogatory comment cut us the way perhaps it cuts a junior learner, we might have a very difficult time. So for very good reasons, many of us have developed a desensitization. But the danger in having that desensitization is the thought that, well, I've done it, everybody else should do it too. And so this sense of like, you got to get a thicker skin might kind of impede your ability to empathize with someone who's experiencing a form of mistreatment that you can't relate to. And so I just want to encourage everyone, especially very senior people who are here, to just recognize that you have good reasons for your own desensitization, but it doesn't stop you from having empathy for those who are more junior to you, who might have a harder time with some of the things that patients say that we're quite used to. And then there's this other thing with desensitization and lived experience, right? Like, I turned 40 this year. And when a patient tells me like, oh, you look young, I'm like, yeah, I do. I'm having a good day. But when a patient tells my student how old are you? You look too young to be a doctor, right? Like that might land very differently. So like, especially in the realm of problematic compliments, like what's a problematic compliment for me, it's not necessarily a problematic compliment for someone else. And that's okay. So if if something is directed toward a junior learner, it might not be quite as flattering or benign as if it's directed toward me. And I have to be aware of that. So this is the hardest one. The idea that we might address mistreatment in real time. And I'm going to start by saying that this is aspirational. We can address mistreatment in real time. I think we should practice. I think we should try. But if we don't, and if we flub it, or we just can't do it in that moment, we don't feel confident enough, or if it makes things worse and causes a patient to escalate, it is okay. We can recover from this. So I just want everyone who's thinking about this, how am I going to do this? How will I do this, with a patient who I have a relationship with? How will I do this with a nurse who I've worked with for 15 years? If you miss this one, it's okay. There's other things that we can do to support learners. But if you're going to go for it, there's ways to be intentional, and there's ways to try to do it well. There's no one right way to respond, and I think that's a reflection of all these different ways that people can get mistreated in the learning environment. But the first thing you might want to do is consider your goal. I'm going to do an intervention. I'm going to say something. What am I hoping to get out of it? What's going to happen after I say something? What do I want for the end of this conversation to look like? Consider your relationship with the person. Consider that you might continue to take care of this person. Consider that you might finish a shift with this person. You might continue your training with this person. What is the context? Specifically, when you're thinking about patients, the context will be very important. If the patient is psychotic, for example, that will be a different conversation than if the patient is angry about long wait times. And your tone is going to matter. So when you kind of are stepping into this emotionally charged situation where you might be unsure of, how you're going to say something, just think about how you're coming across and how you're going to deliver this intervention in a way that allows you to achieve your goal. When I think about consider my goal, when I do an intervention, I'm usually doing one of three things. And those three things are stopping unwanted behavior, educating, or sending a signal. So if I have somebody who is unloading on my student and telling them what a terrible job they did, and making racial or ethnic slurs toward them, I need that to stop sometimes. I might do an intervention that just sort of says, you can't speak that way. You need to stop speaking that way. And I'm not trying to educate someone. I'm not trying to tell them why it hurts or what the context is or why this is inappropriate. I just need it to stop. Sometimes there's room for education. Sometimes there's a moment where you can say, actually, have you considered how this might be not a great way to express yourself? This might be a better way to express yourself. This is something that I might do with colleagues, someone I'm a little closer to. And sometimes what's going to happen is I'm going to say something, not because the behavior is going to stop. The behavior will continue because the patient is intoxicated. Not because I'm going to be able to educate the patient because the patient is intoxicated. But I'm still sending a signal as a leader, and I'm kind of drawing everybody under my wing and showing how I expect a professional encounter to go. It's not going that way, but I still recognize for everybody in the room what the leader has in mind. So, kind of touching on this idea of considering the relationship, we've talked a lot about patients as perpetrators, and the difficulty that lies in kind of maybe educating a patient, taking a stand against something a patient is doing, but still you have to take care of them. You have to continue to work with that patient. But I also want to acknowledge that it's really hard to do this with colleagues. and the people you're going to work with, and especially colleagues that you don't know very well. It may seem that if you're going to do a bystander intervention, it has to happen in real time. It has to happen, because you're sending a signal as a leader, because you're taking a stand. But it really doesn't. And one of the things that you might do is just wait for things to diffuse and still do your intervention, but take them aside after the shift. If you still have to work like half a shift with someone and it's you're gonna, you don't have time to have a really in-depth and thoughtful conversation, maybe you defer that intervention, and do it after the shift, and then you can kind of talk more and really come together on, understanding each other. If you're friends with the person, that could go either way, right? You could have like a very productive conversation, or you could have like kind of a feeling of like, hey, we're friends. Why are you doing this with me? So you have to consider that as well. And we talked about context, we talked about what can be achieved with an intoxicated patient, for example, is not the same thing as what can be achieved with a frustrated patient, or simply an effusively complimentary patient. But I also wanted to point out that where we work can be very public, right? So if something is happening in the hallway because a patient is being seen in a hallway spot, there's everyone around us, right? So there may be a role for moving that situation, especially if it's a physically charged situation, into a more private space. But also to just acknowledge that what you're doing now is being witnessed not just by your team and by your patient, but everyone else in the hallway. So the idea of doing an intervention in public versus in the relative privacy of a room is something that's not to be taken lightly and has to go into the consideration. And also the issue of physical safety, if that's the case, to ensure that you have physical safety before you kind of do an intervention that might cause someone to escalate. And so as you approach with intentionality this intervention that you've decided to do, you want to think about your tone. And your tones will pretty much align with your goals. The idea of taking a stand is a different tone than a non-judgmental correction. And this idea that you can adopt a certain tone in private, a more relaxed tone, a more inquisitive tone, versus when you're in public, it might be a little harder to have that kind of dialogue. So we're going to go through some examples. All of the examples that I've brought for you today are examples of mistreatment that has been either perpetrated on me when I was a trainee, or they come from my harassment and mistreatment reports that I get from students. So the first example is derogatory language. Someone once said to me, "Shut up, dyke." And the other example was a student was a witness to a patient being verbally aggressive with a nurse, and the patient said, "Don't touch me, bitch." So in that situation, you imagine perhaps the patient is a little dysregulated for whatever reason, we're not sure. And what you can do in that case is use language that sets clear limits, and use language that shows your intention to have inclusive leadership. And so if you see this happen to another person, you can say, "We treat everyone with respect on this unit. We cannot tolerate that kind of language." And kind of focusing on the language and not the person, I think is a nice touch. Being able to say, that the language is the problem, but still kind of you're the patient, we're the doctors. Please don't speak to staff that way. That language is inappropriate. Again, you're using the verbiage of professionalism. You're still saying please. You're using words like that language is inappropriate, and you're kind of very specific about what you want. And hopefully your patient will be able to meet the limit that you set. But even if they can't, and even if they continue to use derogatory language, what you've done is kind of extended your wing to those around you, right? You acknowledge we are a staff, we are together, we treat everyone with respect on this unit, we are all together. And in that way, you kind of make sure that everyone knows that when you're speaking as a leader to encourage respect for those around you. I see something in the chat. Yes, the point that you are focusing on language and not saying you are being inappropriate, it helps people to be more receptive because you're identifying a behavior, not something wrong with an individual. Thank you for making that that really clear. So the next problem that we're going to look at is the problem of microaggressions. These are examples from mistreatment reports and from my life. So when am I going to see the doctor? And the resident is female. And I remember one time, I just walked out of the patient's room and like the attending was kind of like standing in the doorway and I like seen the patient like walked out and then the attending was like walking in as I was walking out. And so the attending walked in and the patient said, as I was leaving, like, when am I going to see the doctor? And I turned around like on my toe and I was like, I'm the doctor. But that was just a moment of exasperation. But it's pretty common. And then this example, the student reported that a staff member said the patient in room 4 has a crazy, unpronounceable name, and the student was of the same nationality as the patient, and so was very familiar with how to pronounce the name and felt kind of singled out as a member of that same nationality, that they were kind of being othered along with the patient and was concerned that, you know, the patient would be treated poorly as a result. And so in those cases, more gently than sort of shouting, I'm the doctor, you can educate and explain what's going on to the patient. If you're my attending in that moment, you can say, Dr. Bod is the resident physician on the team. She's been taking care of you. We've discussed your case. I'm here to meet you as well. But we've been working together this whole time, something like that. And in the second case, I think there is a role for intervening in the moment. You could say, let's go ask the patient how to pronounce their name, like kind of saying, okay, let's go together. The patient has a name. We care about who they are. Let's go get it right. But if that seems difficult, what you might do is wait, and you might take that person aside later and say, you know, the way you kind of referred to that patient as having a crazy name, you know, I don't think you meant any harm, but some people might find that to be dismissive or like kind of a put down. And I wonder if there's a different way to handle that. And you could talk to someone and have a longer conversation about it. And the last example is the example of problematic compliments. These are the ones where it's easy to let them sail by, but people do walk away with a kind of ick feeling when it happens. And especially if those problematic compliments kind of have a sexualized implication about, you know, how somebody looks or something like that, might actually really be disturbing to the individual. So once a patient said, I'm so lucky to have a strong, handsome medical student. And another time when it was an all-female team, a patient said, I think it's great to have a female doctor, a female team. You're so much more nurturing. Um, and in that moment, I'm like, I don't know if I identify with that, but in this case, I do think there's a way to preserve the relationship, to gently redirect and reframe. You're not taking a stand. You are showing inclusive leadership, but really you can kind of talk about why this is not the best way to address the physician taking care of you. And you could say the medical student is very smart. They're taking great care of you. That's the most important thing. And kind of turning attention back on why the medical student is there and what they're meant to be doing. And similarly, you can say all the doctors here will try to listen to you with empathy. We're all going to try to take good care of you. And this way, you can kind of reset this idea that there's any kind of gendered behavior that's inherent to female doctors or male doctors. So, like I said, The intervening in real time, it's difficult. It can take many forms. It's aspirational, and if you mess it up, or don't seize the moment and don't do it, it's okay. But the thing you really have to do every time is support the learner, and figure out how what happened is affecting those around you and see what you can do about it, because that's what the learners want. That's what my students want. They want to feel like somebody has their back and somebody cares. Different learners will have different reactions and will need different levels of support. You can imagine a student who is their first day on clerkships and they encounter a very dysregulated patient that might need a different level of support than a sub-intern who experiences a microaggression. And so the first thing to do is acknowledge the incident with a simple check-in. One thing you want to avoid is to be pedantic or patriarchal in your approach, kind of saying like, I'm going to make this go away for you, or I'll take care of this for you. But rather, the better way to take care of this is to involve the trainee in the decision-making around the incident. Some trainees might want to report an incident, let's say, to Office of Professional Development. Some trainees might not. And so kind of giving them their leeway to kind of decide, and that empowers them, and it helps them kind of move forward from the incident. And then to encourage speaking up about incidents of mistreatment. Again, the subtle message that we can send that says, toughen up, get a thicker skin. That message needs to kind of actively be counteracted. And so to encourage speaking up, to say, I want to hear about that. Yeah, that seemed like it would really bother me too. If I was a medical student in your position, I'm here to talk to you about that. Can go a long way to counteracting that toxic message that we get from training sometimes. So a little bit of language. I like scripts. I like to know what to say. So a little bit of language that we can use. That was a difficult encounter. How are you feeling? I'm just acknowledging there was difficulty here. You might have feelings. I'm curious, what are they? If it's a situation where you're not sure if the person wants to continue taking care of the patient, you can say something like, I understand that continuing to work with that patient could be difficult. And leaving it in the hands of the trainee, because you don't want the trainee to feel like they're being pulled off the case. That doesn't feel great, but you give them the opportunity to walk away from something that might be, continuing to threaten their ability to function on shift. And I remember I once was taking care of a patient who made verbal derogatory comments toward a nurse. And I went over to the nurse afterward and I said, he spoke out of line. Do you want me to ask the charge nurse to see if there's a ability to reassign this patient? And the nurse like burst into tears and she said, no one has ever done that for me before. Like no one has ever offered that for me before. And the fact that I was willing to go up her hierarchy and do something nice that really, just offering to do it like made a big difference in how she felt that day. So kind of just offering and then seeing what happens. She stayed with the patient actually. In situations where there's a few options, anonymous reporting, escalating to other levels of the educational hierarchy, you can say, we have some options in this situation. What would feel right to you? And then some of the words that you can use to identify yourself as a safe person. I want to hear when things like this happen. I'm committed to supporting you and everybody on the team. So the final E is to encourage a positive culture. So that's what I try to do, outside my clerkship. I do faculty and resident development. In addition to bystander interventions, I think about how to broaden my sensitivity and understand what's going on around me, even if I do not identify with some of the microaggressions that are happening around me. So educating myself about my own biases and also the biases of others. Identifying point people across the educational continuum, I'm fortunate to have a really close working relationship with the residency leadership, but sometimes UME, GME, we can feel a little siloed from each other. So getting together and working together on projects like these and how to kind of make the learning environment safe for everyone. And then sharing values with point people at other training sites so that we can bring this idea that we can take care of each other in the emergency department to other areas and other colleagues outside of our own institutions. So I'm just going to summarize the main takeaway points. Mistreatment of trainees is common. It impacts the learning environment and people's ability to learn. And trainees report that team leaders don't address incidents of mistreatment, and that's really what they're looking for this to be addressed in some way. Erase that we can expect that these things will happen, and we can prepare, we can get ready. We can recognize mistreatment, address the situation in real time or not, but we can always support the learner after the event and establish a positive culture. When you choose to intervene, that intervention will depend on your goals, your relationships, and the context in which the incident occurred. But the best first step you can always do is acknowledge that the incident happened and check in with people. Support for the learner can take different forms, and empowering people can be something that you try to do. And you can continue to develop a positive culture for yourself and for the trainees that are coming after you. So thanks for your attention. And if you have any questions, I'm happy to try to answer them.
Thank you. That was such a good session. And I was particularly looking forward to this Cord Connects because this is not something that, comes so naturally to me. And I think that, whether you're someone that this comes naturally to or not, it takes some work, but it's particularly hard for folks who haven't had a whole lot of experience and it doesn't come natural to them. And I like some of the methods that you've outlined here, particularly for having those difficult conversations, either in the now or shortly thereafter. My question is, you outlined a couple ways to go about those tough conversations with the not the target of the mistreatment or the perceived mistreatment, but the origin of that perceived mistreatment. And you focused on respect and on language. Do you have any other pointers, any other talking points that you tend to stick to that tend to be better received, less inflammatory, and make for a better conversation?
Yeah, I think also, if someone sort of exhibits a level of embarrassment or kind of, oh, well, I didn't mean any harm by that, to acknowledge that and to kind of to be soft, right? To kind of have your this idea that you might take a stand is a very hard way of thinking about it, but you can still take a stand with some softness. And not every intervention is going to be, this kind of big correction. It can be a softness. And I think people respond well to that. And especially people who are trying to get you to like them, right? Like if you imagine the patient, why are they giving you a problematic compliment? They want you to like them. You're taking care of them. They're in a very vulnerable position. So kind of trying to balance that. Like I'm trying to educate someone who wants me to like them. I think I do like them. I will talk to them as though I like them. I think that's helpful.
Thank you for that. And folks are posting lots of resources in the comments that I am following the links to and bookmarking right now. And there was a question from Dr. Schiante, who says, suggestions for when the folks displaying the problematic behavior are kind of out of our control, like nursing or ancillary staff.
Yeah, so I think that's one of the hardest ones, depending on the relationship. It's almost easier when you don't know the person very well. And it, as you get more advanced in your training, right? It's hard for a resident to have this conversation with a nurse, but it's not super hard for an attending to have a conversation with a nurse, especially like a new nurse, and just to say, hey, that kind of language can be misperceived. I wonder what you meant by it, and have a little bit of a conversation. Um, I imagine doing that, and I imagine it going okay for someone I don't know that well. But if I know them kind of well, like it might be a little stickier. Um, I would say there's always the option if you think someone is a repeat offender, who needs an intervention by their own, control mechanism, their own hierarchy, that you can do so and, move laterally to someone else's hierarchy, to their supervisor or something like that. Um, but if you're going to do your intervention, I'll give an example. I had a nurse that I didn't know super well who repeatedly misgendered a patient who was trans, and they did it because not because they were being actively disrespectful, but because the patient was a trans woman who had a urological complaint, and it was so hard for her, for the nurse, to refer to the patient as she when the issue was urological, and we were and it was hematuria, and we had to talk about her penis. So that was hard. Um, and and I said to the nurse, I notice you're misgendering the patient. Like, what can we do? Like, how are we gonna kind of move forward? We need to work with this patient, and we want her to feel like we care about who she is as a person. Um, how can we work together on this? And the nurse was so receptive and apologetic, and we decided to go into the room together and just say, we are trying hard not to misgender you, and we know that it's really difficult when that happens. We are going to do our best and apologize in advance for any slips. Um, and I think that brought her level of anxiety down, and she kind of stopped doing it, because she was less worried about doing it. I was worried about doing it too. So that's just one example, but like kind of sussing out how you can kind of talk to the person, um, and make that assumption that we all want to do right, um, as the clinical team. Now, if you identify someone who doesn't want to do right, then you have to kind of move to other options.
I was going to say, I really also appreciate your perspective on problematic evaluations and also problematic complaints, because I think this is a really unseen and often unaddressed area for residents and students, especially. For example, like when we give people their summative feedback at the end of a rotation, like I'm a clerkship director also and a sub-internship director. And so we need to go through the comments and start looking to see, did someone make a comment like, she's very well spoken, in a way that you may speak about a black student and not a white student, or, the patient was shy, or the student was shy when referring to someone who's not dominant or aggressive in the room, and then is actually polite and leaves other people a chance to speak, right? So we do have it for like our resident evaluations. Our nurses are allowed to do like just-in-time evaluations for the residents, and so we review these because we had a black resident who was consistently being evaluated as not being patient-centered or friendly to patients, even though my experience with this resident was that he was a very friendly person, but he just doesn't do like the saccharine sweet kind of sing-songy sweetness to patients. And so we had to remove those evaluations from his evaluations because we just don't want the resident seeing things like that, because that can actually like really bring down morale and bring down his ability to work with those individuals. So we go through and try to scrub those things out. And then then, like I had a comment where a resident or a student was wearing a resident was wearing glitter to an outside event. It was like a conference, and was asking people if they wanted glitter, and people were saying yes, and he was putting glitter on everybody. And then after the resident left, a bunch of the EMS people came by and said, "Oh, that effing F-bomb," saying all these words and saying, "Oh, I should have beat him up for trying to put glitter on me." And one of my faculty came to me and asked me to talk to the resident about not offering people glitter. And I was like, actually, you missed this huge opportunity to be like, we don't allow people to threaten violence against our residents. And we actually missed a huge opportunity to protect our resident and to correct those people. So people sometimes will come to you with hey, can you adjust this behavior, or tell this person to tone it down, or not wear their tattoos, or not wear their earrings, or all these different things that we might get complaints about. So I think it's such a huge point that we don't realize this hidden curriculum that students are being told to change their personalities, or people who are neurodivergent being told don't say when you're presenting, or don't have a fidget spinner, or don't have things that help you to actually focus and do your job effectively. And so I know that was something that stood out to me as a very unrecognized source of mistreatment of students that I think we forget to think about. So thank you for bringing light on that.
Yeah, thanks. And thanks for highlighting it in particular, because when I think about how I'm evaluated as an attending sometimes, the kind of the weight that I put on it, I have to consider it in a with humility. Maybe someone is trying to tell me something important, but also with a sense of personal dignity and integrity. And that ubiquitous thing that you identified, especially, it needs to speak up more, that kind of thing. Sometimes that's where we get into the gray zone. I love the gray zone. So thank you. Yeah, it's given me something to think about.
Well, thank you so much. If there are no other questions, then we'll go ahead and wrap up. Thank you so much, Dr. Bod. This has been an amazing session, amazing discussion. And thank you again, everyone, for the questions and the resources that you posted in the chat. I look forward to revisiting the recording a little bit later too, because there's a lot to learn from this. Thank you all so much.
Thank you.